Okay, good morning everyone. Welcome to this first board meeting of NHS Direct in 2011. Also in our new offices, our new London office at Leman Street. So well done for finding us. That's good. We of course are streaming our board on the web again. The first time from this room, so I'm sure we'll discover some issues about the way the acoustics work and the way the cameras work. So could I ask people who are watching us on the web to please feedback your experience of what it's like, and we will learn from that. Of course, I should remind you that it's a working meeting, not a performance, and so it won't be perfect, but we're hoping that it will be clear and easy to follow, and that watching on the web will be a valuable experience. Okay, so I'm going to start with apologies for absence. Steve Duncan, Non-Executive Director, is not able to be here today. We're also waiting for one of our Executive Directors, Trish Hamilton, Acting Clinical Director, and she's held up on a train on her way here. I'm sure she'll join us soon, trains permitting. I haven't got any declarations of interest for the agenda today. We're going to be looking at the register of interest later on in the agenda. If there are any particular interest people have in anything on today's agenda, could they please tell me now? No? Okay. Let's then move on to the minutes of the meeting that was held on the 20th of December last year. Do we have any matters of accuracy on those minutes? No, very good. Thank you, Keisha. And then we will move on to the... We've got in here as an addendum to the board meetings of Finance Committee, Clinical Governance Committee, for which we had verbal reports last time. I'm going to just take those as read. And moving on to the action log.
Sorry, John, just before we move on from that, in governance terms, sure. I would have thought the minutes should appear as a separate item on the agenda and be formally approved. Otherwise, if you're trying to locate the minutes of subcommittees, you never actually see them appearing on an agenda.
That's a very good point.
They just disappear.
Yeah, absolutely. Okay, no, that's very helpful, Trevor. We'll do that in the future. Well, yes, Ruth.
I'm sorry, apologies. There was one final correction which I'd like to see in the minutes under 19.1.1.
19.1.1.
So it says it was noted that the call levels were very low in the North East service, which led to staff being idle for long periods. I would remove the words in the North East service. I think the issue is the low call volumes across the board.
Okay, thank you. Louisa?
I'm not sure quite how you handle this, Chair, but I just had a couple of questions. So obviously they're not sort of matters of accuracy around the clinical governance meeting.
Mm-hmm.
Can I ask those questions?
Yes, you can.
Okay, so the first question was around a paper on patient death. I wondered if it was appropriate in the light of advance support for the board to see those. That's my first question.
I believe the intention was that we would be including that.
Okay. Yes. All right. And then my next question was to do with the risk of staff not adequately picking up the level of call of concern. I thought allied to that there was an issue that Tim's raised around picking up when there are repeat calls.
Yes.
And escalating those repeat calls.
It's good Tricia's not here actually.
Yeah.
Because do you want to?
Well, I think both Renette and I have experience of this, but it's essentially one of our internal procedures has now been changed to increase the priority given to patients who are phoning back with worsening symptoms. And continuing to express anxiety. So we've changed that procedure and increased the priority so that those patients are much, much more likely to speak to a clinician and indeed to receive a referral onwards to a face-to-face service.
If required, therefore, once they've spoken to the clinician.
Yes.
Yes.
So on the patient deaths, is that paper going to come to the board as an agenda item to be discussed? We're not sure, but it will in some form come to the board.
I think it's important that the board sees it.
Yes.
We're still discussing exactly how that should come.
Okay.
Yeah. So the issue is, having had the initial discussion at the Clinical Governance Committee, and this is a report on all of the circumstances relating to calls where the patient subsequently died, and that could include, for example, calls where we called a 999 ambulance straight away and the patient subsequently died in hospital. But as a matter of routine, we look at all calls where there is a patient death. So as a result of that, each individual call is analysed. At the Clinical Governance Committee, we looked at what are those lessons that need to be learned from looking at the totality of all the calls, and that is work that Tricia is working on. That will come back to the Clinical Governance Committee, and I would suggest at that point we'll be able to present the full picture to the board. Is that acceptable?
Yep, okay. Good, thank you. If we're ready, then we'll move on to the action log. Nick, do you just want to pick up anything that it doesn't necessarily look to me as though there's anything we want to particularly raise today?
Well, I think there's a few things that are due, and I just need to check with my colleagues. Two of them I think are for Tricia, so she's not here, so that will be problematic to pick up. The first was the comment made about the proportion of people going through health and symptom checkers that didn't actually complete the assessment. I don't know if Renette can report on that.
I thought it was easier to report at the board since it's a number. 84% of people who start a symptoms checker reach a disposition. So
84%?
84% on average.
So therefore 16% don't.
Don't, yes.
Is that changing on that? Is that...
I've asked the team to pull, that's the data from the last 6 months, but of course we've just in December had a large number of symptom checkers that have just gone live, so we'll keep that under review. That's for the last 6 months, that's what the figures are.
And how do you feel about that number?
That's a good result.
Yeah, I think so.
Okay.
It feels like a good result.
Are there any comparators that would help us understand for other similar tools, not necessarily in the health sphere, what a good completion rate is like?
I suppose one of the comparisons we could look at would be another thing that we've produced, which is our old self-help guide, which has been online for the last 6 years or so. It's probably longer than that, probably 8 years. So I could look to what the completion rate used to be for that. I think this is much higher. I haven't looked at those in that detail.
Good. So we're broadly satisfied and we're confident that that represents good performance.
Yes.
Good. Thank you. Well done.
Thank you.
All
Okay.
right.
If I may, I'll leave open the two that Tricia's reporting back on. The other one, I'm not entirely sure what the action was. It looked more like a suggestion than an action that one could report back on. But Ruth, I don't know whether you can comment on the question about involvement of ourselves with local ambulance trusts to see whether we could improve the service given to care home residents.
We were looking at this in the context of the South East region, but it hasn't been our priority given the activity around 111, which we've been focusing on. So I will report it back to the teams and see if there's an update.
Okay. So
I don't think this is something that we need to
fine.
Drill down into. It was a useful suggestion if it works good.
Yeah.
All right. Let's move on quickly then to my recent engagements, which you will see are few in number, but high in content. No, not even that actually. I'm afraid that I didn't get to the seminar on the future of professional regulation at the King's Fund because we had a meeting with Martha Lane Fox, the digital champion, instead. So let me just say a couple of things. I've looked at the slides from the King's Fund seminar on professional regulation, which is focusing on doctor revalidation. They're actually rather good, and if anybody's interested in seeing them, I'm happy to share them. Okay, well, I'll send them around, and people who aren't interested can dump them. Then the meeting that unfortunately displaced that one, which was with Martha Lane Fox, the government's digital champion, was a very good one. She doesn't have a formal remit. She has a remit to look at channel shift within government and how government can make better use of multi-channel in all of its services. She doesn't have a very specific remit around health, but partly because of her own personal experience, she's very keen on doing more within health. And I think the meeting served to encourage her in that direction, and hopefully we will find ways of working together to deliver the undoubted benefits that we all had some degree of understanding of, that would accrue to patients and the NHS with better use of multi-channels in health. So that was very positive. Okay, fine. Let us move on then to the more content-rich Chief Executive's report.
Thank you. I will attempt to be brief. If I may, I'll just touch on the first three very, very quickly. There is a great deal going on within NHS Direct and between us and our main commissioning partners on the development of 111, the organisational and business plan consequences of that for NHS Direct, and the changing landscape within the NHS, of course, with the change in who will be commissioning services in the future. So the brief report that I've given under the three items, the strategic overview of 111, producing a 5-year business plan, and the consultancy support that we've got to support our strategic work, reflects that fluidity. Each of those items is work in progress, but we would hope certainly by the time we have our board strategy days in March and the April public board meeting, that we would be able to present a much more comprehensive and clear picture. So if I can, I'll just skip over that. Obviously happy to answer any questions. Board assurance framework is there for the board's information. This is the new format that's been through, and again, feedback or questions very welcome. If I can pause briefly on the Foundation Trust status. As the board will sorry?
No.
All right. Sorry, I thought you right.
I put you off your stride there.
Yeah,
Apologies for that.
Foundation Trust status. As the board will remember, we have already taken a decision in principle that we wish to pursue FT status. We had that discussion in November, and indeed Joanne wrote to the Secretary of State to confirm that subsequent to that discussion. What is outstanding, therefore, is putting a timetable, which is what the Secretary of State's original letter asks us to do, to that intention. And we are in very active discussion with our current main commissioner, the East of England, and with the Department of Health on trying to get some clarity about when we are likely as an organisation to be able to have a forward order book for our services that will underpin a business plan. And as we speak today, we can't have that. The body that that commissions over 80% of our work is abolished in April 2012. We don't, as we speak, yet know who will pick up the commissioning responsibility after that. We also are not clear at what point, although it's becoming clearer, at what point the new longer-term contracts for running 111 services will be let. We believe that will be during 2012. So we are attempting to firm up those timetables with the Department of Health, and once we're clear, then we will be able to put a more solid timetable to our own FT status ambitions. Clearly, as you will probably remember, the Secretary of State asked that Joanne replies to him by the 18th of February, and therefore we're hopeful that the things that we need to have clarified before then will be so clarified. If they're not, then I think it will be a question of simply restating what we have already stated, which is that we are keen to become an FT, and as soon as the Department of Health's timetables are clearer about the rollout plans for 111, the sooner we will be able to put a realistic timescale to our own FT aspirations.